Okay. Thank you very much for the
You are
invitation.
welcome, Professor.
Can you hear me? Okay. Yes.
Okay.
So thank you very much for your invitation to talk about current bronchoscopy guidelines in the COVID-19 era. I'm joining you from Athens. I'm an interventional pulmonologist. I'm the national delegate for Greece in the European Association of Bronchology and Interventional Pulmonology and chair of a relevant committee in Wabi.
So,
So where do we stand?
so, so,
Can you hear me?
so,
Okay, so for sure 2020 was a year that shook the face of the earth. This is the initial WHO report on a cluster of cases, 44 patients with pneumonia of unknown etiology reported to WHO by the national authorities in China, in Wuhan. Soon, China recognized the new pathogen and managed to decipher the genetic code. And this has since led to a worldwide pandemic, leading to strict measures, lockdown, social distancing. You can see here pictures from last year that still remain contemporary, pictures from Italy and Greece on the right side. Uh, it's the same situation here in Athens, even today, which is a national holiday. Uh, Last time, 6 months ago, when I had a talk here in Greece about the pandemic and bronchoscopy, I checked this site in the Johns Hopkins site for the COVID-19. Then the cases were 9 million, the global cases. Now, today that I checked, the cases were 124 million and the fatalities were more than 2.5 million. So the problem is really actual, and especially regarding bronchoscopy, we have a lot of issues. You heard a lot about bronchoscopy in the ICU from Professor Popovich in an excellent speech. And our issues are that, first of all, symptom-based control of patients is not sensitive enough. This has been proven. So if we have an asymptomatic patient with COVID-19 and he undergoes routine bronchoscopy, the endoscopy team and other patients in the surrounding areas may become exposed. This is because bronchoscopy is a respiratory droplet spreading procedure, and the bronchoscopy unit with infected doctors or nurses or patients can create a super spreader situation. Also, when we're talking about patients that undergo bronchoscopies, we are talking about a particular group of patients that are immunosuppressed. They have malignancies or pulmonary infections, so this is a special group that has to be cared about. So what are the relevant questions? First of all, should we check all patients with swabs prior to bronchoscopy? When should we do a bronchoscopy of a patient that is suspicious for COVID-19? Which indications are considered an emergency for bronchoscopy, and which international guidelines should we follow? The first national guidelines that appeared and published were the Chinese guidelines from the Chinese Thoracic Society. The major problem with these guidelines that came really early on in March of 2020 were that the first thing is that they were in Chinese, so few people had the chance to translate them. I tried to translate them then, and the basic parts are that bronchoscopy is not a mean to diagnose COVID-19. We have to adhere to strict regional safety protocols. We have to examine carefully what are our bronchoscopy indications. We have to postpone non-urgent procedures. We have to set all patients to thermometry and lab tests to see if they have an active infection. We have to separate suspicious versus non-suspicious cases. The personnel must be geared up with high protection masks, N95s, and visors, and gowns. When we do bronchoscopy in suspicious cases, we prefer to have a negative pressure room, And for confirmed or suspicious cases, we prefer tracheal intubation or laryngeal mask for less spread of droplets. We have to distance our patients in the waiting room, and we have to regularly decontaminate the bronchoscopy suite, if possible with UV light. Also, all personnel should be trained with proper donning or doffing of protective gear. So these first guidelines appeared, and then shortly after, the American Association for Bronchology and Interventional Pulmonology followed and made some first recommendations published in the Journal of Bronchology Interventional Pulmonology back in March 2020, with the main purpose of ensuring the safety of patients and healthcare team. This shortly followed by the consensus of chest AABIP guideline and expert panel report. This is a much more detailed work. So this panel of experts set a set of questions regarding the population, which is the suspect or confirmed cases or asymptomatic. They set up interventions, compared them to the past, and measured and proposed the outcomes. So the first recommendation of this panel of experts is when patients with suspected or confirmed COVID-19 infection are undergoing bronchoscopy, we suggest that healthcare workers in the procedure and recovery rooms use either an N95 respirator or a powered air purifying respirator. This is not very routinely used, at least in our practice in Greece. It's this elaborate mask on the right. But for sure, additionally, when we use the N95 respirators, the healthcare workers must have a visor, a face shield, a gown, gloves, and relevant equipment. Also, there is a strong recommendation that these masks, the N95 respirators, should be discarded after bronchoscopy. A second recommendation is that in patients suspected or having COVID-19 infection, a nasopharyngeal specimen should be obtained first. So bronchoscopy is not, of course, the first mean of detection of COVID-19. We must take one or more repeated swabs. When we have a clinical or a radiology suspicion for COVID-19 disease, then, and of course the swabs are negative, then we can consider for the patient to undergo a bronchoscopy and collect a bronchoalveolar lavage. As you can see in this study, using bronchoscopy for diagnosing COVID-19 disease is not that frequent. When we had 3 negative swabs done in 3 different days, and the negative serology, then all of the patients that underwent bronchoscopy, all 20 patients were negative for COVID-19 in this study. So if we use the repeated swab method, it's quite probable that we can exclude COVID-19 with almost certainty. On the other hand, there are other studies that, as you can see, we have a lot of patients that have clinical or radiology images that are very suspicious of COVID-19, but we have negative swabs. In this study, they swabbed 36 patients, and with the initial swabs, they had 30 patients that were tested positive. 6 cases were initially missed. From these 6 patients, they used an elaborate scheme of repeated swabbing after on the first day, and then on the second day they did 2 swabs. On the third day they did 1 swab, and they found 3 more patients. Then the 3 that were left and they were positive, they had to undergo swabbing on the 5th, on the 6th, and on the 8th day respectively. So this study shows that in some cases, not the majority, it's very difficult to continue swabbing till you find all positive patients. And the authors conclude that the CT sensitivity for finding COVID-19 was 97%, whereas the sensitivity of the initial swab was only 83%. That is why some of the patients need to undergo bronchoscopy for detection of COVID-19. This study was organized in Italy during the pandemic last year, and despite three consecutive negative swabs, 50% of patients were with relevant clinical and radiological features for COVID-19 were positive, 43 out of 78. So still, there are patients that will be diagnosed with bronchoscopy for COVID-19. We have, of course, the issue of asymptomatic patients. When we are doing elective bronchoscopies, it is preferable and it is mandated to do a PCR testing prior to performing bronchoscopy. Even when we have negative tests, we should treat this patient as positive and gear up with the N95 mask, the gown, the gloves, as if this patient was positive, because there are cases that the swab is negative, but maybe the second or third or a bronchoscopy sample would be positive. So the personnel must be geared as if the patient is positive. We already talked a lot about the bronchoscopy in the ICU. I just put this study because it is a real study of bronchoscopies, and in 100 bronchoscopies in an ICU unit, mostly for atelectasis, secretion management, or detection of superinfection, as previously discussed by Professor Popovich. I would like to say that disposable scopes were really useful in this case. The Ambu scopes that they use also in Serbia, we use them in Greece as well. It is very dangerous to do bronchoscopy in these patients. 1 out of 2 bronchoscopies got infected. It is important to prepare before going into the ICU for a bronchoscopy. All equipment must be ready. We have to have a checklist and see what we need. We cannot run outside to take what is needed and get back in. The bronchoscopy must be very short, less than 10 minutes if possible, and you already saw the endoscopic findings, the mucus plugs and the inflammatory situation of the mucosa. So this is us. We are preparing for a routine IP procedure. The patient is swab negative, but we are geared up and we are ready as if the patient was positive. And here is an Indian colleague that is wearing this air purifying respirator. As you can see, we do not use them routinely in Greece. This is a picture from India from a colleague. Several techniques have been published for aerosol protection during intubation or bronchoscopy. You can see on the left some elaborate constructions for protecting personnel, and on the right you can see more simpler solutions as covering up completely the patient to not allow droplet dissemination. Here is a very interesting study, recent from BMJ. They used just a stretcher and some materials from camping to form what they call the splash BV design. It can be used for transporting patients throughout the wards, or doing a bronchoscopy or emergency bronchoscopy in the COVID unit, or intubation, of course. It's very interesting, and you can find it in the link down here if you want to construct such thing for your patients. Of course, it's very important to stress that all these protective strategies are useless if we don't know how to don and especially doff the protective gear. So we have to be completely trained. I was amazed of the detail that I had to be trained by an infectious diseases nurse. When they trained me, I thought that I could put the gear and take it off without any problem. I discovered that there are many problems, and I had to be trained and retrained again. And if you want to find more details about donning and doffing, you can see the 2 links with videos that can help you prepare about this procedure. So we have a pandemic, but we also have a lung cancer epidemic inside the pandemic. Current guidelines are adamant that we have to focus and prioritize on the diagnosis and staging of lung cancer. We have to allocate resources. We have to not to stop any bronchoscopies in favor of COVID-19. We have to continue to fight for our lung cancer patients, not only to diagnose and stage, but also to treat. So we have to make sure that resources are allocated for oncology and surgical treatment as well. Of course, delays are evident. You can see even in the UK, you can see a study here in BTS presented that showed that there were delays during the peak of the pandemic in the UK for flexible bronchoscopy. And of course, there were less procedures done during the peak than after the peak. This is only reasonable. Even the best health systems in the world cannot cope, but we have to try to allocate more resources for lung cancer. This is clearly stated in the current guidelines. So we have emergency bronchoscopy, such as tracheal stenosis, malignant, benign. You saw the videos from the Professor Popovich before. We have massive hemoptysis or migrated stent. These are really emergent situations. We have to treat them immediately. We have urgent bronchoscopy, such as lung mass suspicious of cancer or mediastinal staging for lung cancer. And we have non-urgent bronchoscopy, such as bronchoscopic lung volume reduction or bronchial thermoplasty or investigation of chronic cough. These must be left a little bit behind. In this paper, from expert bronchoscopists, it has been stated that for stage 1 and 2 cancer that really needs not to be staged. We can skip bronchoscopy and use percutaneous CT guided biopsy or consider resectional biopsy as a first mean in order to avoid droplet formation during bronchoscopy. And this, of course, is a little bit controversial as regards the side effects of punctures or surgery and the efficiency of these procedures. So when can we do an elective bronchoscopy at a patient that has been infected by COVID-19? The guidelines are not very clear at the moment. It is considered that we should wait for about 30 days or have at least 2 swabs that are negative in 2 consecutive days. Then we are quite safe to proceed with bronchoscopy. I have participated as the ex-chair of the Interventional Pulmonology Group in the Hellenic Thoracic Society in writing the current Greek guidelines for bronchoscopy in the era of COVID-19, and I urge all societies to participate in such a procedure. It is very fruitful and it's very important for us to follow up on our current bronchoscopy practice all the time. What is our preferred anesthesia method? It is considered that if we use moderate to deep intravenous sedation and we use a tracheal tube or a laryngeal mask airway, it is safer to do elective bronchoscopy because we have a control over the droplet formation. This is not always, of course, easy because an anesthetist is not always available. We are using this particular laryngeal mask, which actually fits anatomically in the larynx and prevents droplet formation. It's very useful, and we have announced these in a previous anesthetist congress, and the patient satisfaction is very high, and the bronchoscopists are as well. So I totally recommend it to you for use. Of course, we already mentioned the disposable bronchoscopes. It's a very easy thing to use. We just have a tablet and a scope. We can use it even when we don't have a bronchoscopy suite in the COVID ward. We can reuse this bronchoscope in one patient at least for 2 to 3 times and sterilize it and use it and keep it in the drawer for the next time. Of course, these cannot be used from one patient to another patient. And the cost is quite significant. It's about $200 each. Uh, Also, this is a recent paper from the Cleveland Clinic summarizing their own institution guidelines. So they have prioritized the use of gear and in each situation in the pulmonary ward, the COVID unit, the bronchoscopy suite. And this is the trend right now. Each institution is making their own customized uh, uh, guidelines according to what is needed in each hospital. So this is emerging, and there are more and more institutions that are creating this hospital individual guidelines. And I would like to close this presentation by showing you these pictures. The one on the left is the Attica Zoo Park in Athens, which was quite doomed for some time because there was a lack of funding, because nobody visited the animals at the moment, so they received a grant from the government in order to survive. But also there are two pictures of hope. These are pictures from our new vaccination center in Athens. It's called Prometheus. Prometheus was a demigod that stole fire from the ancient Greek gods and gave it to man. So it's considered a symbol of hope in Greece. With that, I would like to thank you for your attention.
Thank you, Professor Phillips, for your excellent presentation. And now, Dr. Nadia, we can join you.